Good morning, all. So I know this 1 hour is going every. Yes, good morning, Ajay. This you are in the final phase of your preparation with every minute of your is precious. So keeping that in mind, I have designed this 1 hour, the 6 a.m. session, like a quick review of almost the major topics in the pathology. So it will be like a discussion of PYQs, and half of the things it will be like a revision of the topics also. So it is going to be a quick, very fast session, so that in this 1 hour we can cover the maximum things. Okay, and a few words I want to tell you before starting the session. Uh, at this point of time, you have to develop your full of positivity. Don't compare yourself with any other person's rank or their other performances in other exams or these things. So only few days are left for your final exam. So focus it very sincerely. Don't bother about any other thing. So this upcoming few days are going to be very crucial for you. That is going to decide your future. Yes, it is going to decide your future. So think that God has given that few precious days for you to maximize your potential. So how எவ்வளவு முடியுமோ அவ்வளோ efforts put in this upcoming days. Definitely every minute of your hard work will be rewarded. Okay, keep that in mind. And லாஸ்ட் ஃபியூ டேஸ்க்கு முன்னாடி இந்த ஜிடிஸ் அதெல்லாம் போட வேணாம். அதெல்லாம் ஜிடிஸ்லாம் லைக் ஒரு 2 to 3 டேஸ் இல்லை 4 டேஸ் முன்னாடி ஸ்டாப் பண்ணிடுங்க. ஏன்னா லாஸ்ட் டேஸ் போட்டு அதை கன்ஃபியூஸ் பண்ணிக்க வேண்டாம். ஓகேவா? ஸோ அதை 3 to 4 டேஸ் முன்னாடியே யூ ட்ரை டு ஸ்டாப் தோஸ் ஜிடிஸ் அண்ட் ஆல். ஸோ definitely you will all do best in the upcoming exam. So we'll start the session. So which of the following is not an example of metastatic calcification? Yes, can I get the answers in the chat box? Which of the following is not an example of metastatic calcification? Yes, I'm started getting the answers. So metastatic calcification and dystrophic calcifications are two types of calcification. Dystrophic calcification occurs in dead and degenerated tissues. But metastatic calcification occurs when calcium levels are normal. Metastatic calcification occurs when calcium levels are increased and that calcium is deposited in a live tissue. So in parathyroid adenoma, in vitamin D toxicity and chronic renal failure, there is going to be hypercalcemia. Whereas in rheumatic heart disease, which is a degenerative condition, here you will be getting dystrophic calcification. In all other things, you will be getting metastatic calcification. So this is the table which tells you about the examples of metastatic calcification: parathyroid tumors, multiple myeloma, Paget's disease, vitamin D related disorders, sarcoidosis, renal failure, milk alkali syndrome, and vitamin A toxicity. And remember, these are the common conditions. Dystrophic calcification occurs, rheumatic heart disease, TB lymph node, atherosclerotic, and monkey bird's medial sclerosis. Calcium deposits in the tunica media. And somoma bodies are examples of dystrophic calcification: meningioma, mesothelioma, papillary carcinoma, thyroid, serous cystadenocarcinoma of the ovary, prolactinoma, glucagonoma. All these conditions you can see the dystrophic calcification. And what is the special stain for calcium? Calcium, the special stain is going to be Oncosa. So remember, a quick review about the special stains and the important components stain. Mason trichrome is for collagen. Verhoeven Van Giesen for elastic fibers. Silver methenamine stain for reticulin. Oil redo and Sudan black for fat. Mallory PTAH for muscle striations. And Martius scarlet blue is for fibrin. PAS for the glycogen and neutral mucin. And Alchin blue, you will remember the acidic mucin, it stains in Barrett's esophagus at pH of 2.5. Alchin blue is positive in Barrett's esophagus. Congo red for amyloid. And Oncosa, the most commonly used in calcium, and alizarin red is most specific. Pearl's Prussian blue for hemocitrin, that is iron. Mason Fontana for melanin. Austen and modified rhodamine for the copper. Tolidine blue, this is was asked. Tolidine blue mast cells, and you will remember for mast cells the new markers are CD117 and CD30 and also tryptase. These are all the other special stains and markers for mast cells. Gomori methenamine silver for fungus. Shikata cells, ground glass hepatocytes seen in chronic hepatitis B infection. That is in hepatitis B antigen. Musicarmine is for cryptococcus. Wathin stari is spirochetes. H. pylori special stain for Wathin is Wathin stari. H. pylori medium is chiromedium. Culture medium for H. pylori is chiromedium. Calcofluor white for acanthamoeba. Zeal-Nielsen stain for acid-fast organism, Machiavelli stain for rickettsia. So remember this special stains, commonly asked special stains, which can be given as a clue. And what is this next question? Which of the following is true about role of telomerase in the aging? Which of the following is true about role of telomerase in aging? Yes? Yes. Very good. Very good. What are telomeres? Telomeres are short sequence of DNA present at the tip of the end of the chromosomes. So every cell division, telomeres length shortens. So at when telomeres length is telomeres are totally lost from the chromosome, the cell stops its division. But cancer cells, germ cells, stem cells have telomerase, increased telomerase activity, so they keep on dividing. Telomerase is nothing but RNA dependent DNA polymerase. Telomerase is nothing but RNA dependent DNA polymerase. So there is normally in normal cells, there is decrease in telomerase activity with aging. Then again, this question on aging. All of the following are true about the sirtuins, except all of the following are true, but one is false. Yes. Yes, I started getting the correct answer. Very good. So sirtuins are the type of histone deacetylase. There are 7 types of sirtuins are there, and the sirtuins actually promotes genes with increase, which increases the longevity. Like actually, this sirtuins are present. Calorie restriction. Calorie restriction is the most effective way to increase the sirtuins. And actually, sirtuins decreases the insulin resistance and it increases the glucose metabolism. It increases the glucose metabolism. So sirtuins are also very important. And also remember premature aging, progeria. Okay, progeria. What is called as adult progeria? Which syndrome? Werner's syndrome. Werner's syndrome is adult progeria. Adult progeria. All of the following are true about amyloid deposition, except all of the following are true about amyloid deposition, except yes. You people are right. Yes, yes. So I take this opportunity, a quick glance about the amyloid. So amyloid, actually it is a proteinaceous substances. It is not a starch. Okay, amyloid is a proteinaceous substance. It is extracellular deposition. So what is the appearance of the amyloid? It is the non-branching fibrils. It is in the non-branching fibrils by electron microscopy. Whereas in infrared spectroscopy and X-ray crystallography, it appears beta plateau sheet. So other name for amyloid is beta fibrillosis. And we know that increased protein synthesis or the decreased protein degradation are the more common causes of this amyloid deposition. So there are many types of amyloid. See this tabular column. So that these are all the most yield areas. So amyloid, there is generalized amyloidosis all over the body. Amyloid is getting deposited. So you have mainly few important types of generalized amyloidosis. AL amyloid, which is seen in light chain deposits in multiple myeloma. AL type of amyloid. And AA type of amyloid, it is the secondary amyloidosis in chronic inflammatory conditions like rheumatoid arthritis, tuberculosis, bronchiectasis, Hodgkin's lymphoma. So the examiner can give you such scenario also. And in those chronic inflammations, you get this amyloid AA. AA, that is amyloid associated. Serum amyloid associated protein is getting deposited. If the examiner gives you long-standing history of chronic renal failure and hemodialysis, you have to think of A beta 2. Yeah. Okay. Remember this kidney dialysis, 2 kidneys. So A beta 2. Yeah. And the hereditary amyloidosis, it is familial Mediterranean fever, AA amyloid, familial amyloidotic neuropathies, ATTR, that is amyloid transthyretin. And systemic senile amyloidosis, though it is said as systemic senile, mainly the cardiac involvement will be common in this type of amyloid. Here also ATTR. Then localized amyloidosis, you will remember senile cerebral, that is A beta amyloid, A beta 1 by Alzheimer's disease. So cerebral Alzheimer's disease, you will be getting that A beta. Alzheimer's, you will be getting that plaque, no? Amyloid plaque. That amyloid plaque is made up of A beta. Alzheimer's, what else you will be getting? What is the other clinical finding, histopathological finding in Alzheimer's? Tangles. Tangles. What is this Alzheimer's? And the tangles are made up of tau proteins. Yes, tangles are made up of tau protein. So this is very important. So then medullary carcinoma thyroid, ACAL. So remember, medullary carcinoma thyroid, calcitonin is the tumor marker, parafollicular C cells it arises from. Okay, so remember that. And amyloid deposition. Thyroid tumor with amyloid deposition, you have to think of medullary carcinoma thyroid. Then islets of Langerhans, it is in type 2 diabetes. Okay, remember, amyloid in type 2 diabetes, APPP, amyloid associated insulin pancreatic polypeptide. Isolated atrial, isolated atrial amyloidosis, AANF, atrial natriuretic factor, atrial natriuretic factor. Type 2 diabetes mellitus, you will be getting amyloid deposition, not in the type 1. Okay, remember that. And histopathology, amyloid is going to look like this, pinkish material. In the kidney, usually glomerulus, it is deposited in the mesangium. So in the Congo, that it is a light microscopy, it will be appearing like this pink color, but in polarized microscopy, it will be going to give you apple green birefringence. The common site for amyloid as a demonstration is abdominal fat aspirate they will be doing, and biopsy from the gums and the rectum is the commonest site for amyloid things. And cardiac involvement, renal involvement is the most common cause. The cardiac involvement cause of death, subendocardium, the amyloid is getting deposited, and amyloid deposition in the white pulp is called as a Sago spleen. In the red pulp is called as a Lardaceous spleen. Okay, these are the possible questions which can be asked from the amyloid. Which of the following is the reason for the cancer cells using this Warburg effect? Warburg effect. Yes. So Warburg effect, we must have heard in the neoplasia. So Warburg effect is nothing but by this effect only, the cancer cells survive. The cancer cells survive because cancer cells, or the main purpose is not energy production. So energy production. So they, even though lot of glucose is available, a lot of oxygen is available, they will not go for oxidative phosphorylation. That is, if the cancer cells utilize the glucose via the oxidative phosphorylation or via the Krebs cycle, they can yield a lot of ATPs, but energy is not needed for them. So even in presence of ample oxygen, they prefer to go for anaerobic glycolysis, so that actually yields less amount of ATP, but that pathway creates lot of intermediate substances which can help the cancer cells to survive. So by using the Warburg effect, the cancer cells use the intermediate products for its survival, because the cell is keep on dividing. So that intermediate products, it is helping to generate that intermediate products. That is Warburg effect. Okay, so please remember that. And also PET scan, 5-fluorodeoxyglucose, radio labeled PET scan. PET scan utilizes this Warburg effect. Okay, so remember these points. And this is the standard question. Yes, which of the following is seen in the mother of mother exposed to this thing, diethylstilbestrol? Yes, clear cell adenocarcinoma of the vagina. Clear cell adenocarcinoma of the vagina. Yes, this is the famous question. So now a quick review about the carcinogenic agents, alkylating and acylating agents, AML. So please remember, benzene causes leukemia, AML. Commonly, benzidine causes bladder cancer. And aromatic hydrocarbons actually causes lung cancer. Benzidine, bladder cancer, benzene, leukemia. Diethylstilbestrol, mothers exposed to diethylstilbestrol during pregnancy, the female fetus in the later part of the life can develop this clear cell adenocarcinoma of the vagina. Aflatoxin, Aspergillus niger flavus. So azodise causes this hepatocellular carcinoma. Also remember RCC, hepatocellular RCC, HCC, and choriocarcinoma are the cancers which prefer to spread via the hematogenous route. Remember that point also. So nitrosamines is going to be a risk factor for gastric carcinoma, polyvinyl chloride for angiosarcoma, asbestos. The most common cancer is bronchogenic carcinoma, and the most specific cancer is the mesothelioma. Arsenic carcinoma skin, cadmium prostate cancer, and nickel lead cobalt chromium for the lung cancers. Okay, so remember all these important points. Which is the most common cancer in the radiation exposed patients? It is the leukemia. The second most common will be the papillary carcinoma of the thyroid. Yes, very good. An elderly male with a history of diabetes was on immunosuppressive drugs. Biopsy of the lesion showed oval budding yeast with a pseudo-hyphae. What is the most likely diagnosis? Yes. We all know that oval budding yeast cells with a pseudo-hyphae, that is candida. In a background of immunosuppression, you will be thinking of the candida. So see this picture. So this is how the candida will be looking like. And what is the special stain? Black color, if the fungal stain, if they are showing you, you have to remember the black color special stain is the GMS, Gomori methylamine silver. Okay, so this will be the, and in the pap smear, you can see this shish kebab appearance. The squamous cells will be attached to the fungal hyphae, that is a shish kebab cells, shish kebab appearance. And where you will be seeing the clue cells in which infection you will be seeing? Clue cells in pap smear? Bacterial vaginosis. So yes, clue cells are nothing but in bacterial vaginosis around the squamous cells, this coccobacilli, Gardnerella vaginalis, this bacterial vaginosis, the cells will be appearing at the borders of the cell. So you will be getting the clue cell. So that is also a question. And you will remember this, if the fungus is having septae like this, if the fungus is having septae and acute angle branching, you will be thinking of aspergillosis. And a fungus with a broad hyphae and branching at right angles, you will be thinking of mucormycosis. Branching at 90 degrees, you will be thinking of mucormycosis. Okay. A patient presented with a hemoglobin of 5 gram, his reticulocyte count is 9%. What is the corrected reticulocyte count in this patient? What is the corrected reticulocyte count in this patient? Yes. So what is the formula to calculate the corrected reticulocyte count? So the corrected reticulocyte count, the formula is actually the retic count into patient to the hemoglobin divided by normal hemoglobin. So here the reticulocyte count is 9 and patient hemoglobin is 5. And we assume that in a male, the normal hemoglobin is 15. So the corrected retic count in this patient is 3. Okay. And the special stains for reticulocyte count is supravital stains. And the name is new methylene blue or brilliant crescile blue. And the reticulocyte, immediate precursor of the RBCs. Actually, please remember the material inside the reticulocyte is ribosomal RNA. Reticulocyte count is increased in hemolytic anemia. So reticulocyte count is decreased in aplastic anemia and iron deficiency anemia, megaloblastic anemia. After therapy only in iron deficiency anemia, the reticulocyte count is increased. Okay. What is Menzer index? What is Menzer index? That is also one question. What is this Menzer index? Menzer index, and what is its use? Menzer index. Yes, very good. Menzer index is MCV divided by RBC count, and it is used to differentiate between the iron deficiency anemia and thalassemia. More than 13 is iron deficiency anemia, less than 13 thalassemia. Okay, so remember the less than 13 thalassemia, Menzer index. Okay, remember this. Which is the correct order of draw of the blood samples in the Vacutainer? Which of the following is the correct order of draw of the blood samples? Yes. Very good. So this is the correct order. So you can see this. First, for the culture, you have to draw the blood sample. So first one, from the culture, for culture, you have to draw the blood samples. Then you have to draw in the for the coagulation studies, blue topped Vacutainer, sodium citrate, and then red topped Vacutainer, then gold, Then heparin, that is the light green vacutainer. Then EDTA, purple color vacutainer. Then the sodium fluoride, that is the gray topped vacutainer. This is the order of the vacutainer drawn. Okay, so this is the order of blood drawing. Okay, a quick review about the vacutainers. So blue color vacutainer, 3.2% sodium citrate, coagulation studies like PT, APTT, and this red topped will have red, no anticoagulant. Serological studies, microbiology and biochemical studies will be there, and for therapeutic drug monitoring. And this golden yellow color for gold, that is containing the powdered glass, which is as a clot activator, and it is also used for serological studies. In addition, thyroid profile and vitamin B12. Light green contains lithium heparin and plasma determinants in chemistry, whereas this dark green is important. So for green, you will remember that genetic study. Green, you will be remember that genetic study. So it contains this sodium heparin and lithium heparin. So HLA typing and ABG analysis, you will be collecting the blood samples from the green color vacutainer. And also remember that purple color vacutainer, that is containing the EDTA, the CBC, and routine hematology and even molecular testing. HbA1c the purple color vacutainer. And all of you will remember that this is a PYQ. Gray topped vacutainer contains potassium oxalate as the anticoagulant and sodium fluoride as the additive, because sodium fluoride inhibits enolase. Sodium fluoride inhibits enolase. So this is used for the glucose estimation. Black vacutainer for the toxicology test, and in the blood banks you will be using this yellow color vacutainer and this pink color vacutainer for blood grouping and cross matching. Royal blue color vacutainer, that is for the trace elements and in the toxicology. So this is a quick review about the vacutainers. All of the following are true about anemia of chronic disease, except all of the following are true about anemia of chronic disease, except. So this is going to be one of the standard questions to differentiate between the causes of microcytic hypochromic anemia. So you will be remembering that microcytic hypochromic anemia, the mnemonic to remember is CTIL, that is sideroblastic anemia, iron deficiency anemia, thalassemia, anemia of chronic disease, and lead poisoning. So all are the causes of the microcytic hypochromic anemia. But in exam, they are going to mainly ask you about the three anemias: iron deficiency, thalassemia, and anemia of chronic disease. Anemia of chronic disease, usually there can be a history of any chronic inflammation like rheumatoid arthritis or tuberculosis, those kind of SLE. So this even malignancies also can be there. So in anemia of chronic disease, there will be interleukin 6 will be elevated. Interleukin 6 will be elevated, and this leads to increased hepcidin. All of you will know that hepcidin is the negative regulator of the iron protein. So main point to differentiate between the iron deficiency anemia and the anemia of chronic disease. In iron deficiency anemia, the total iron binding capacity is raised. In iron deficiency anemia, total iron binding capacity is raised. Whereas in anemia of chronic disease, it is reduced. Very important point. Another important point, in iron deficiency anemia, the storage form of the iron, serum ferritin, is reduced, whereas it is increased in anemia of chronic disease. HB electrophoresis is going to be abnormal. HB electrophoresis is going to be abnormal in thalassemia minor, and in sideroblastic anemia, most of the things are going to be raised, and it is free erythrocyte porphyrin levels are decreased. In sideroblastic anemia, you will be getting ring sideroblast. What are ring sideroblast? Sideroblasts are nothing but they are ring sideroblasts. They are seen in two conditions: sideroblastic anemia and myelodysplastic syndrome. That is in a Pearl's Prussian. That is in a Pearl's Prussian stain. If you do that in a bone marrow, the erythroblast will be having that circles. Actually, they are the iron content that's stored in the mitochondria. So you need at least five continuous circles, or 1/3 of a circle. By this, you definitely define the ring sideroblast. So coming to the option, in anemia of chronic disease, serum hepcidin is going to be increased, adequate or not, increased iron stores, low total iron binding capacity, but serum ferritin is going to be increased. So this is the wrong option. Then, as you all know that the trend is on the blood transfusion. So which of the following blood product storage and temperatures is correctly matched? And as you can see here, I wanted to, yes. Yes, yes. So this is the correct, actually, the blood product. So quickly we'll go through the blood storage temperatures. So whole blood and packed RBC. hmm? Whole blood and packed RBC are stored at +2 to 6 degrees centigrade, and with the additive. What are all the additives in RBCs will add? Will add ACD. So remember from this, you remember the ionicity question was asked. If it is only ACD, acid citrate dextrose, it is for 21 days. Citrate phosphate dextrose, now it is also 21 days. But to increase the shelf life, they will be adding CPDA, that is citrate phosphate dextrose adenine. At add panna, it is 35 days. And remember, if you add a SAGM, sodium adenine glucose mannitol, SAGM, the shelf life of RBC is increased to 42 days. Okay, so that is very important. Platelets 72 hours, and actually it is usually stored with a agitation. And remember, fresh frozen plasma and cryoprecipitate, they can be at -25 degrees centigrade. They can be stored up to a period of 1 year. And RBC has to be transfused like within half an hour. You get it from the blood bank, and the transfusion should be completed within 4 hours. Platelets should be transfused as soon as possible, and it has to be completed within 20 minutes. And a fresh frozen plasma, it has to be first thawed because it was in a frozen state. It has to be thawed. Then after that, it has to be transfused as soon as possible. So transfusion has to be completed within 20 minutes. And remember this components also, because I hope you remember the question was asked. So packed RBC, the volume of the blood is, or the volume of the bag is 240 ml. Platelets, the volume is 50 ml. Fresh frozen plasma 250, and cryo it is 40. And the constituents, platelets, you have predominantly platelets. FFP, the constituents are fibrinogen, antithrombin 3, factor 5, and factor 8. Cryoprecipitate, it is fibrinogen, factor 8, factor 13, von Willebrand factor. And remember, 1 unit of PRC will increase the hemoglobin by 1 gram per deciliter. And the platelets will increase, 1 unit of platelet transfusion will increase the platelet count by 5,000 to 10,000. And FFP and cryo increases the fibrinogen by 10 milligram per deciliter. Also, please remember fibrinogen. What about this thing? In DIC, how the blood parameters will be looking? There will be increased bleeding time, increased PT, increased APTT, and increased thrombin time also. Yes, so fibrinogen will be decreased, and fibrin degradation products will be increased. Okay, so understand this. So DIC, all will be increased. Fibrinogen will be decreased, and fibrin degradation products will be increased. And platelet is also going to be decreased. That is the blood parameters in DIC. Okay, blood parameters in DIC. Which of the following is not true about parvovirus? Which of the following is not true about parvovirus? Yes, yes. So parvovirus, we know that it is the slapped cheek appearance, aplastic crisis. Please remember, parvovirus causes pure red cell aplasia. Parvovirus causes pure red cell aplasia. And in background of hemolytic anemia, it causes that aplastic crisis. Can you remember any tumor which can cause pure red cell aplasia? Any tumor which can present as a paraneoplastic syndrome causing pure red cell aplasia? Thymoma, paraneoplastic syndrome, very good, excellent. That is actually pure red cell aplasia. So it also can cause non-immune hydroxypyrolysis, but it will not be associated with SLE, non-erosive arthritis. This is the wrong option. So remember that it affects the pro-erythroblast. Parvovirus, fifth disease, erythema infectiosum, dog-ear appearance of the cytoplasm, and it produces that intranuclear inclusions. Please remember that. And match the following. Is the Clara cells. Clara cells are seen in the bronchioles. Yes, Clara cells are seen in the bronchioles. Dust cells are seen in the alveolar macrophages. Kupffer cells are seen in the liver, and parietal cells are seen in the stomach. Okay, so remember that Clara cells for the repair, they will be present in the terminal bronchioles. Clara cells, Clara cells. What are the three C's in bronchial asthma? You will remember, guys. Three C's in bronchial asthma: Kirschmann spiral, Crayola bodies, charcoal-laden crystals. Kirschmann spiral is that sputum with that shed epithelium. Charcoal-laden crystals are nothing but galactin-10, eosinophil-derived protein, galactin-10, that is charcoal-laden crystal. And also Crayola bodies in the bronchoalveolar lavage, you will be seeing that Crayola bodies. Bronchial asthma, two types, intrinsic and extrinsic asthma. So extrinsic asthma, allergy, all this thing, children, IgE will be elevated, immune basis, eosinophils. Intrinsic will not have that. Samter's triad. What is Samter's triad? Asthma, nasal polyps, and asthma, bronchial asthma, nasal polyps, and aspirin intake. That is Samter's triad. Yes, very good. And a quick view of modified macrophages. Bone, it is osteoclast, brain microglial cells, kidney mesangial cells, liver Kupffer cells, lung dust cells, lymph node sinus histiocytes, placenta of Bayer cells, spleen littoral cells, and blood, it is monocyte. What is the counterpart of basophil in the tissue? It is mast cell. Bloodla vandu basophil. Tissue you call that cell as a tissue you call it as mast cell. A 45-year-old female who is non-smoker was diagnosed with adenocarcinoma of the lung. Which of the following markers is or are positive in this patient? Yes, yes, I know it is a double option of the napsin A and TTF1. Yes, both are right. Okay, please remember that both are right. Both are right. Yes, TTF1. Yes, both are right. Napsin A and TTF1. Both are positive in adenocarcinoma of the lung. Okay, so remember that. And about a quick review about the cancers, the most common malignancy in lung is metastasis, and the most common primary malignancy is adenocarcinoma. So adenocarcinoma is the most common cancer in non-smokers, young adults, females, and it occurs in the periphery, late presentation, poor prognosis. And TTF1 and napsin A are the tumor markers. Squamous cell carcinoma, hilar location, and it is associated with the smoking, earlier presentation. Squamous cell carcinoma associated with cavities in the lung, and it is associated with hypercalcemia as the paraneoplastic syndrome. You will be thinking of squamous cell carcinoma. Small cell carcinoma, most aggressive cancer, poor prognosis, strongest association with malignant is with smoking, lot of paraneoplastic syndromes you will be seeing. Markers for small cell carcinoma is synaptophysin, chromogranin, yes, synaptophysin, chromogranin, or NSC, neuron specific enolase, bombesin, CD57, BCL2. And in small cell carcinoma, you will remember that Azzopardi effect. The nuclear material will be smudged around the blood vessel. And squamous cell carcinoma, what are the markers? P40 and P63. Okay, so remember that. Carcinoid tumors also will be positive for synaptophysin and chromogranin. Whereas the synaptophysin chromogranin will come positive even in your pheochromocytoma, also synaptophysin and chromogranin positive. And one more question with pheochromocytoma, the sustentacular cells will be positive for S100. S100 positivity you can also get in this neural tissues, schwannoma, neurofibroma, and also S100, CD1A, CD2, yeah, melanoma also. S100, CD1A, CD207 positive. Which disease you will think of? Langerhans histiocytosis. Langerhans histiocytosis, you will remember that tennis racket appearance, Bilbach granules. Bilbach granules. What is the triad of a Handschuler Christian disease? Triad of Hanschler Christian disease, bone lesions, exophthalmos, diabetes insipidus. Okay, that is the triad of this Hanschler Christian disease. You remember, you will be seeing nuclear grooving will be there in Langerhans cell histiocytosis. Nuclear grooving, coffee bean appearance with ovarian tumors. You will remember this Brenner tumor, granulosa cell tumor. Okay, granulosa cell tumor, papillary carcinoma, thyroid also. You will remember that nuclear grooves. And this is also one of the PYQ. What are all the diagnostic investigations for these tumors? Which is the correct answer you feel? So, Marjolin's ulcer. So, Marjolin's ulcer, what do you know about Marjolin's ulcer? Marjolin's ulcer is actually the ulcer which arises in the burns patient, which can turn into squamous cell carcinoma. So, the Marjolin's ulcer, the background, you have to know that the squamous cell carcinoma is a very important complication. So, to prove that, yes, very good. To prove that, what you will know, you want to rule out any invasion. அப்ப invasion இருக்கா அப்படின்றத செக் பண்றதுக்கு என்ன ஆகணும்? Marjolin's ulcer, you have to do the wedge biopsy to assess the invasion. Sarcomas, that is a big mass. So sarcoma, big mass, you want to identify what type of sarcoma. So you will be doing a core needle biopsy. You will be doing a core needle biopsy in the sarcoma. The patient is presenting with a single tiny lymph node swelling. Single tiny lymph node swelling. Usually FNAC will not be will be difficult in that single lymph node swelling. So you will be excision. You will be doing an excision biopsy. Excision biopsy. And solitary nodule of the thyroid. Usually it is better to go for ultrasound guided FNAC because the blind FNAC sometimes will be yielding only the colloid. So usually they will be doing this ultrasound guided FNAC. So the answer here is B. Very good. A 35-year-old patient presented with the symptoms of passing dark color urine is a known case of G6PD deficiency. Ingestion of which medication? Yes, we all know that. Even if chloroquine and primaquine is given, we have to choose primaquine because it is more common in this thing. G6PD deficiency, we remember it is X-linked recessive disorders and males are more commonly affected than females. So that oxidative stress, either infections or there is a history of malaria or infections, naphthalene balls or fever beans, there's the oxidative stress. So what happens? The sulfhydryl groups of the hemoglobin is getting precipitated. And what is that body? Heinz bodies. How Heinz bodies can be demonstrated? Heinz bodies can be demonstrated by the supravital stains, and you can see this bite cell, blister cells, ghost cells, helmet cells. So all these things you can see in G6PD deficiency. What is the triad of PNH? What is the triad of PNH? The triad of PNH is intravascular hemolysis. Yes, intravascular hemolysis, pancytopenia, and thrombosis. Thrombosis. And early morning urine sample will be showing that hematuria will be the PNH. What is the test done in, common test done in PNH? It is a HAMS test. And which is the diagnostic test? Flow cytometry is the diagnostic test which can demonstrate the absence of CD55 and 59 antigen. So that is the flow cytometry is the diagnostic test in the PNH. Yes. A 15-year-old boy presented with bone tumor in the left upper tibial diaphyseal region with periosteal reaction. Histopathological examination of the lesion showed small blue round cells which are positive for MYC2 and synaptophysin. MYC2 and synaptophysin. So all of you know that it is a Ewing sarcoma. So MYC2 positivity. MYC2. What else will be positive in Ewing sarcoma? Ewing sarcoma, it is CD99 is also positive. Where else CD99 will be positive? CD99 will be also positive in granulosa cell tumor. Okay, CD99 is also positive in granulosa cell tumor of ovary. Granulosa cell tumor of ovary, CD99. Yes, very good. CD99 granulosa cell tumor, even inhibin will be positive. Remember that inhibin will be positive. And osteosarcoma, it occurs in metaphysis, sunray appearance, and it is a bone form. Yes, very good. Sunray appearance, bone forming tumor, Codman's triangle you will be remembering. And what is the type of osteoid you will be getting? Lace-like osteoid, osteosarcoma. And this osteoclastoma, you will be getting that soap bubble appearance or eggshell calcification. It is a light lesion. The actual tumor cells are nothing but the spindle-shaped cells. The osteoclastic cells are just like a reactive on this thing. And diaphyseal tumor, that is Ewing sarcoma, it is the primitive neuroectodermal tumor, a bone tumor which can present as a infection osteomyelitis like a symptom. Pain and tenderness will be there. Onion skin appearance. Where all you will be getting this onion skin appearance? In hyperplastic arteriosclerosis, onion skin appearance, and also in primary sclerosing cholangitis. Remember that onion fibrosis, yes, onion skin fire, I think. And primary sclerosing cholangitis, P ANCA will be positive. Remember, C ANCA positive where? C ANCA is positive in vaginous granulomatosis. Yes, P ANCA will be positive in microscopic polyangiitis, Church-Strauss syndrome, ulcerative colitis, and this primary sclerosing cholangitis, and 25% cases of vaginous granulomatosis. So remember that. Okay. Patient presenting with a history of recurrent fever, hematuria, histopathologic examination of this thing revealed a polypoidal lesion with this basophilic inclusion body. Basophilic inclusion body. What is the most likely diagnosis? The most likely diagnosis is going to be a malakoplakia. So this is nothing but in malakoplakia, the macrophages will be appearing this eosinophilic material. Eosinophilic material. So this is the spotter. So you can see this eosinophilic material or nothing but this malakoplakia. So like a quick review about the vasculitis, different types of Michaelis-Guttman bodies. Yes, these are all called the Michaelis-Guttman bodies. Excellent, Balamugan. This is the Michaelis-Guttman bodies. I just 2 to 3 minutes I'll take to revise the entire vasculitis. Large vessel vasculitis, giant cell arteritis, otherwise called as temporal arteritis. Patient will be presenting with the headache is the commonest symptom, and jaw claudication pain is the most specific symptom of this thing. Sudden blindness due to the ophthalmic artery involvement is the most dreadful complication. ESR will be elevated. Normocytic normochromic anemia. Temporal artery biopsy is the indicator things. The other large vessel vasculitis is the Takayasu arteritis, otherwise called as pulseless disease. Aortic arch syndrome, subclavian vessels are involved. Upper limb BP and pulses are low compared to the lower limb pulses BP. This is in contrast with the coarctation of the aorta. Medium vessel vasculitis, polyarteritis nodosa, and Kawasaki. Polyarteritis nodosa, small disease, you will remember that actually fibrinoid necrosis will be very prominent in this. Polyarteritis nodosa, hepatitis B antigen history will be there. PAN doesn't, P is not for P, PAN spans the pulmonary vessels. And also renal artery is the commonly involved artery, and glomerulonephritis is not seen usually. And different stages of the lesion can be seen in the same blood vessel. That is very important. Then Kawasaki, we know that young child with presenting with a myocardial infarction due to the coronary artery aneurysm, and this cream, you will be remembering that criteria, fever plus cream. Yes, fever plus cream. Conjunctivitis, that is non-purulent conjunctivitis, rashes, edema, erythema, cervical lymphadenopathy, and it is mucosal involvement, that is a strawberry tongue. That is Kawasaki. Then moving on to small vessel vasculitis, microscopic polyangiitis. Microscopic polyangiitis, you remember that it is exactly opposite of the PAN, and the PAN is ANCA negative, microscopic polyangiitis is P ANCA positive. So microscopic polyangiitis, pulmonary vessels are involved, glomerulonephritis is seen, and all the lesions will be of the same age. Then vaginous granulomatosis, it is a triad of necrotizing vasculitis, necrotizing lesions both in the upper and the lower respiratory tract, and crescentic glomerulonephritis, RPGN. Yes, you remember that. That is in vaginous. C ANCA will be positive. Cavities in the lung is possible. Septal perforation will be positive, but the necrosis is fibrinoid necrosis. But it is in the tuberculosis, cavities in the lung can be seen, patient can be presenting with hemoptysis, but TB, caseous necrosis will be there. Okay, so that is a very important thing. Then Henna-Scholin purpura, HSP, hematuria in a small child with presenting with the purpuric rashes, you will be seeing, and Paga, that is purpura arthritis, glomerulonephritis, abdominal pain, IgA deposits in the vessel wall. The patient will be developing the symptoms usually after a respiratory or a GIT infections. Then Church-Strauss syndrome. Church-Strauss syndrome, what are the points you will remember? It is allergy, asthma history will be there, and eosinophils depositions in the vasculitis will be there. In the vessels will be the eosinophil deposits in the vasculitis. And also you'll be remembering Behçet's disease. Behçet's disease is a triad of genital ulcer, oral ulcers, and uveitis. Remember that. And Burgess disease, thromboangiitis obliterans in a young smoker. So young smoker less than 35 years presenting with a claudication pain, you will be remembering this thromboangiitis obliterans. But if it is an elderly male, say what some 70-year-old presenting with a claudication pain, now your answer should be peripheral vascular disease. If this Burgess disease patient presenting with a resting pain, you will think of the nerve involvement. So artery, vein, nerve, all the three are involved in Burgess disease. So remember all these points. Yes, this we discussed. A 5-year-old child presented with multiple osteolytic lesions in the skull, and the tumor cells are positive for S100, CD1A, Langerhans, CD207. Remember that it is Langerhans cell histiocytosis. Yes, eosinophils. Yes, match these things. Sézary cells, we will be seeing in. Sézary cells are seen in mycosis fungoides. Fagot cells are seen in acute myeloid leukemia. Popcorn cells are seen in Hodgkin's disease. Starry sky appearance in Burkitt's lymphoma. Sézary cells are nothing but the nucleus, the cells, the tumor cells with the cerebriform appearance. And this is seen in mycosis fungoides. Cutaneous T-cell lymphoma. So T-cell markers CD3 and CD4 will be positive in Sézary cell in this mycosis fungoides. And the mycosis fungoides, what else you will remember? Collection of the malignant lymphocytes in the epidermis, that is Porteous microabscess. And the lymphocytes will be moving towards the epidermis. That phenomenon is the epidermotropism. Yes, very good. And also, where else you will be seeing that embryo cells, hallmark cells, and reniform cells, donut cells, that is anaplastic large cell lymphoma, ALK mutation, chromosome 2. Remember all this thing. Fagot cells, the oerods, the myeloblast with a lot of oerods, that is you will be seeing in the AML. So you'll remember APML, acute promyelocytic leukemia, AML, M3, that is 3-letter complication, DIC, ATRA is the treatment for that. And the popcorn cells, remember that it is seen in the Hodgkin's lymphoma, that is nodular lymphocyte predominant. 5 types are there. The first 4 types are called as a classical. Okay, mixed cellularity, lymphocyte rich, lymphocyte depleted, and nodular sclerosis. These are all called the classical type. And the 5th one, nodular lymphocyte predominant, is the non-classical one. Why? Because all these 4 classical ones are positive for CD15 and CD30, but this is CD15 and 30 negative. But please remember, this nodular lymphocyte predominant is BCL6 positive. What are all the BCL6 positive now? What are all the tumors you will be thinking? BCL6 positive, you will think of Burkitt's lymphoma, DLBCL, and a nodular lymphocyte predominant. BCL2 positive now, you will be thinking of follicular lymphoma. BCL2 now, you will be thinking of follicular lymphoma. Cyclin D1 now, you will be thinking of multiple myeloma and mantle cell lymphoma. You'll be thinking of cyclin D1. Annexin 5 now you will be thinking of apoptosis. Annexin A1 now you will be thinking of hairy cell leukemia. Hairy cell leukemia you will be thinking of the fried egg appearance. Hairy projections will be seen and better appreciated by phase contrast microscope. They are made up of ribosomal lamella complex. Atypical mycobacterial infections are common in hairy cell leukemia because of the this monocytopenia will be there. So remember all this thing point. And hairy cell leukemia, dry tap will be seen. Okay, dry tap will be seen. Remember that. Aplastic, in addition, where you get dry tap, aplastic anemia, MDS, myelofibrosis, faulty techniques, all this thing you will be seeing that is okay. Then starry sky appearance in the Burkitt's lymphoma. Burkitt's lymphoma, what is the gene you will remember? You will remember c-Myc gene. Burkitt's lymphoma, c-Myc gene, that is in the chromosome 8. Okay, remember that. And the Burkitt's lymphoma, aspirate, you will be seeing cytoplasmic vacuolations. Where else you will be seeing cytoplasmic vacuolation? ALL-L3 you will be seeing. ALL-L1 is small homogeneous blast. L2 is large heterogeneous blast. L3 is cytoplasmic with cytoplasmic vacuolations. Where else you will see starry sky appearance in the immunofluorescence, that is in the post-streptococcal glomerulonephritis. Then in the coming to one quick review, quick review about the glomerular diseases in the kidney. So the post-streptococcal glomerulonephritis, you will be remembering the acute infectious glomerulonephritis. Any infection can cause that. You will be seeing that hypercellular glomeruli, and starry sky appearance in the immunofluorescence, and how the deposits will be there. Post-streptococcal glomerulonephritis, how the deposits will be there. It is the lumpy, bumpy deposits, subepithelial deposits. And remember, guys, RPGN is going to be an important topic in glomerulonephritis, rapidly progressive glomerulonephritis, otherwise called as crescentic glomerulonephritis. How many types of RPGN is there? There are mainly 3 types of RPGN is there. Type 1 RPGN, which is called as the anti-GBM, and that is a good pasture disease. And what is this? Mainly alpha-3 chains are affected. But patient, it affects also the alveolar capillary basement membrane. So the patient can present with both hemoptysis and hematuria. Yes, very good. Type 4 collagen. And this is the type 2 RPGN is nothing but the immune complex. So immune complex, now what you will be thinking, SLE and PAN, all this thing, HSP, all this thing are the immune complex. And what is how the immunofluorescence is going to be in, yes, in linear pattern is seen in anti-GBM. Granular pattern is seen in immune complex. Very good. Granular pattern is seen in type 2 RPGN. Whereas type 3 RPGN, it is actually pauci-immune. There are no immune deposits, but it is ANCA positive. So type 3 RPGN, you will be getting that vaginous and microscopic polyangiitis, all these things. Okay, so remember that. And the spikes and dome appearance, where you will be getting spikes and dome appearance in membranous nephropathy. Membranous nephropathy is prone for, is seen in malignancies, and it is tend to produce clots. Okay, because antithrombin is lost, proteinuria is there. And also where you will be seeing the tram track appearance, you will be seeing in MPGN. Tram track appearance, yes, very good. Tram track appearance in MPGN. And minimal change disease, most common cause of nephrotic syndrome in child, minimal change disease. And food process flattening, where else you will be seeing a food process flattening? In membranous nephropathy, diabetes also, you can see the flattening of the food process. And minimal change disease, otherwise called as podocytopathy, and lipoid nephrosis, because lipid cells will be the lipid engulfed tubular cells will be there. Minimal change disease, good response to the steroids. So please remember all these things. And also Alport syndrome, it is a triad of hematuria, the ear defects, sensory neural hearing loss, and the eye defects is there. And very good. Alports, remember alpha 5 chains are affected. Basket wave appearance in the electron microscopy. And foam cells you can see in the interstitium. This is about the Alport syndrome. Tell me some causes of flea-bitten kidney. Flea-bitten kidney, you will be seeing in the vaginous granulomatosis, yes, henosulin purpura, polyarteritis nodosa, malignant hypertension. Yes, very good. So in all these conditions, you will be seeing this flea-bitten kidney. And where you will be seeing the thyroidization of the tubules or the colloid cast, you will be seeing in the chronic pyelonephritis. Yes, chronic pyelonephritis. And remember, VHL gene, chromosome 3, and it is implicated in RCC. Okay, clear cell RCC, the cell of origin is the proximal convoluted tubule. Okay, and which renal cell carcinoma is bilateral and multifocal? It is papillary RCC, where you can see the foam cells and also the somoma bodies met-proto-oncogene mutation. And the worst carcinoma, RCC with the worst carcinoma, it is biliary duct carcinoma. RCC seen in a sickle cell anemia, you will be thinking of medullary carcinoma. Sickle cell anemia plus RCC medullary carcinoma. And RCC in a young adult, you will be thinking of XP11 translocation. RCC can have metastasis to the small bones of the hands and the feet. So remember all these things. Yes, a 35-year-old male presented with a painless, slow-growing neck swelling. His cervical lymph nodes were enlarged. Surgery was done and the histopathological image is shown. And which of the following is not true about the lesion? So as you can see here, the nuclear features are very characteristic of this lesion, and this tumor carries excellent prognosis, and it will be having a rapid spread to lymph node, and FNAC is not diagnostic. So as you can see, what is this diagnosis? You can see the papillae in the cross section. So this is the papillae and this is the fibrovascular core. And how the nuclear appearance? The nuclear appearance is clear. Okay, the nuclear appearance clear. So what is this? Orphan Annie eye nuclear. Okay, orphan Annie eye nucleus. A quick review about the and the FNAC is diagnostic. Okay, the tumor actually FNAC is not diagnostic. FNAC is diagnostic in papillary carcinoma. A quick review about the carcinomas of thyroid. Papillary carcinoma is the most common cancer. It is strongly associated with thank you for that. Automatically it got thing. Papillary carcinoma is the Yes, thank you. Papillary carcinoma is the most common cancer. It is strongly association with radiation exposure, and recently they have included Hashimoto thyroiditis as the risk factor for papillary carcinoma of the thyroid. Papillary carcinoma thyroid, common metastasis to the lymph node. Distant metastasis is rare. Papillary carcinoma thyroid can present as a occult primary. That first the lymph metastasis will come to attention rather than the primary. Papillary carcinoma carries best prognosis. Okay, so please remember that. And what are all the nuclear features? You will be seeing that orphan Annie eye nucleus and the nuclear grooving also will be the somoma bodies, can be the dystrophic calcification. Follicular carcinoma, and please remember follicular adenoma and follicular carcinoma. Follicular adenoma is benign, follicular carcinoma is malignant, and to differentiate that you need a you need a biopsy. FNAC cannot differentiate follicular adenoma and follicular carcinoma. Please remember that. Only a biopsy can tell that whether it is a capsular invasion or vascular invasion. It is demonstrated only in a biopsy, not in FNAC. A very important point. Follicular carcinoma arises in the background of a long-standing goiter. Lymph node metastasis is rare. Distant metastasis is common in follicular carcinoma thyroid. Okay, so remember that. And medullary carcinoma thyroid can be associated with the Men's syndrome, sporadic or familial Men's syndrome. So where you can do that prophylactic thyroidectomy. Remember that. And Men's syndrome, medullary carcinoma thyroid, parafollicular C cells, and tumor marker calcitonin amyloid. Anaplastic carcinoma, worst prognosis, poor thing. Okay. Now, match the following. Yes. So c-KIT mutation, this is going to be one of the common question for you. So every INSIT or NEET, they are asking this. c-KIT is GIST, and KRAS is for lung cancer, and ERB2 is for breast cancer, and PDGFRB is for astrocytoma. So a quick view about the list of proto-oncogenes and associated tumors. As all of you know that this tabular column is very essential. So we are going to quickly go through this tabular column. PDGF beta, astrocytoma, EGF3, stomach, bladder and breast cancer, HGF for HCC. Please remember, EGF for mutation, adenocarcinoma of the lung, HER2, breast cancer. RET is for MEN2 and medullary thyroid cancer. KIT mutations can be seen in GIST as well as in seminoma. ALK mutations can be seen in ALCL and adenocarcinoma. KRAS, colon, lung and pancreatic. HRAS for bladder tumors. NRAS for melanomas. ABL, CML. And BRAF is going to be important. Melanomas, colonic cancer, hairy cell leukemia, Langerhans cell, histiocytosis. Papillary carcinoma thyroid, pilocytic astrocytoma also, BRAF mutations will be seen. C-MYC for Burkitt's lymphoma, L-MYC for LLL, small cell lung carcinoma, N-MYC for neuroblastoma. Cyclin D1, mantle cell lymphoma, multiple myeloma, CDK for gliomas and melanomas. And remember this tumor suppressor genes, APC, prophylactic colectomy is done in APC, that is for the FAP, familial adenomatous polyposis. NF1 for neurofibromatosis, NF2, that is Merlin gene, NF2 and schwannoma meningioma. Patched gene for BCC, SMAD2 and SMAD4 is for juvenile polyposis. And RB gene, remember retinoblastoma, and the second common malignancy in RB gene mutation is osteosarcoma. And VHL gene for RCC, STK11 for Peutz-Jeghers syndrome. And E-cadherin mutation is for gastric carcinoma and invasive lobular breast cancer. P53, you will be remembering Life-Romani syndrome, BRCA1 and 2, familial breast cancers. WT1 for Wilms tumor, the chromosome is, it is chromosome 11. Menn syndrome, it is menin. Can I take 5 to 10 more minutes? There are a few more questions. Yes. Thank you for the confirmation. A chronic alcoholic patient presented with increased abdominal girth and abdominal girth and decreased liver span. Liver biopsy showed this cytoplasmic eosinophilic material in the hepatocytes and the cytokeratin positive. This is most likely composed of intermediate filaments. So what are these things? And what are these things? These are called as Mallory-Denk bodies or the Mallory-Hyaline bodies. Mallory-Denk bodies or Mallory-Hyaline bodies made up of CK8 and CK18. Okay, please remember CK8 and 18 positive. Okay, this intermediate filaments. So that is this Mallory-Hyaline bodies. Which of the following is an anti-apoptotic gene? Yes. BCL2, MCL. If it ends with LLL, you will think that it is lowers the apoptosis. Okay. So remember about the apoptotic. Pro-apoptotic genes are BAX, BAC, and BCL excess. Anti-apoptotic genes ends with L. And you have these 5 types of BH3 proteins: BIM, BAD, BID, NOXA, and PUMA. BCL2 is an anti-apoptotic. We know that there are 2 pathways: intrinsic pathway, otherwise called as a mitochondrial pathway, in which normally what will happen, BCL2 acts like a guardian against this mitochondria, so that the cytochrome C is present inside the mitochondria. During apoptosis, when intrinsic pathway is activated, what happens, that BCL2 is inactivated. So the cytochrome C comes out of the mitochondria. Then it will activate caspase. Intrinsic pathway caspase 9 is activated. Then extrinsic pathway is via the death receptors. TNF, TNF and FAS are the death receptors. And remember, CD95 is the marker of apoptosis. Then in extrinsic pathway, caspase 8 is activated. Both of them activate the common executioner caspases 3, 6, and 7. Then this, what is caspase? Caspase is cysteine derived aspartate, cleave that aspartic proteases which cleaves that aspartic acid. Okay, so remember that. And what is mainly then endonuclease is getting activated. It cleaves the nucleus into oligosomes of 200 base pairs. Remember that, 200 base pairs. And these all the dead things are packed under the apoptotic bodies. These apoptotic bodies express the thrombosporin and phosphatidylserine, and by this the macrophages engulf this thing. Because of this, there is no inflammation in apoptosis. In necrosis, there will be inflammation will be there. In necrosis, the cell size will be swollen, and in apoptosis, there will be cell shrinkage will be there. Necrosis, it is always pathological. Apoptosis can be either physiological or pathological. So remember all these things. And also remember this step ladder pattern commonly seen in apoptosis. Smudging and smearing pattern can be commonly seen in necrosis. So remember, either way it can occur, but commonly step ladder na apoptosis, and necrosis na it is a smudging or the smear pattern. A 70-year-old male man presented with enlargement of multiple lymph nodes. CBC revealed a total count of 65,000 peripheral smear findings are shown. Which of the following is the best needed to confirm the diagnosis? Best needed to confirm the diagnosis. Yes. Yes, very good. So all of you know that this is a case of the CML where you can see the mature lymphocytes, lot of mature lymphocytes, and these cells are the smudge cells or the smear cells or parachute or the basket cells, and this is a convent girl appearance. And the CLL, usually this thing, leukemias, you will be seeing that flow cytometry. But remember, FISH is the diagnostic investigation of the choice in the CML. Okay, remember that is CML. And CLL, please remember, if the count is less than 5,000, it is SLL, and more than 5,000, it is clonal lymphocytosis, it is CLL. And CLL associated with the warm IHA, and cell of origin is naive. And please remember, CLL is CD5 positive and CD23 positive. Both the CD5 and 23 will be positive in CLL. Please remember that. And the Richter transformation, CLL can transform into an aggressive lymphoma like a diffuse large B-cell lymphoma or pro-lymphocytic leukemia. And CLL can be associated with the secondary malignancies like your melanoma and the brain tumors. A female presented with skin thickening and pain in the fingers on exposure to cold and muscle weakness. She was positive for ANA and SCL70, which is the other antibody most likely to be positive in this patient. Yes. So for this, we know that this is a case of SCL, skin thickening and pain in fingers, exposure to cold, Raynaud's phenomenon. That is actually, it is a systemic sclerosis positive. Yes, we know that this CREST syndrome is more common in the limited scleroderma, and actually it is the anti-SCL70. Anti-SCL70, if it is positive, it is actually diffuse scleroderma. Anti-SCL70, it is positive, it is diffuse scleroderma. Please remember that. Very important. Note down this. Here it is SCL70 they have shown. Though the patient is having all these symptoms, there is positive for SCL70. This CREST syndrome, limited scleroderma, usually it is positive for anticentromere. This anti-SCL70 is positive in diffuse scleroderma. Anti-SCL70 is positive in diffuse scleroderma. Okay, so the diffuse scleroderma, the positivity is fibrillary, anti-U3 RNP. So please remember the catch here. The anti-topoisomerase is the most specific antibody in scleroderma. Anticentromere is, yes, anticentromere is CREST syndrome, but here they have given anti-SCL positivity. So anti-SCL positivity, now it is diffuse scleroderma. So the answer here is anti-U3 RNP. This is a very tricky question. Yes, this is a very tricky question, but the answer is anti-U3 RNP. You can see this tabular column given in our workbook. Okay. I think we have seen this question. And trisomy 13, a very easy question for you. Trisomy 13 is for Patau syndrome, trisomy 18 for Edwards syndrome, trinucleotide repeat disorder, Huntington, and point mutation, sickle cell anemia. So remember that trinucleotide repeats, Fragile X, it is CGG repeats, Friedreich ataxia, it is GAA, myotonic dystrophy, it is CTG, Huntington disease, CAG, spinocerebellar ataxia, CAG. Okay, so remember these things. And genomic imprinting, what you will be remembering? Maternal deletion, Angelman syndrome, happy puppets. Paternal deletion, Prader-Willi syndrome, profound hyperphagia, obesity will be there. Okay, so remember a quick review on how to differentiate the different patterns of inheritance. Different patterns of inheritance, autosomal dominant, all the generations will be involved. Both males and females will be affected. Vertical transmission. Autosomal recessive, both males and females can be involved, but there is skipping of the generation, and this now you will be thinking of autosomal recessive. Yes. Then X-linked recessive, males are affected, females are carriers. Okay. And or X-linked dominant only, it will be confusing to you. X-linked dominantly, all the generations will be involved. Both males and females will be affected, but father will be transmitting the disease to all the daughters. Remember that very important point. In X-linked dominant, father is giving the X chromosome, only having one X chromosome, father transmitting the disease to all the daughters. If it is in the pedigree, you will be thinking of X-linked dominant. Okay. Mitochondrial inheritance, affected father will not transmit the disease to any one of the children, but affected mother transmits the disease to all the children. Mitochondrial gene is inherited from the mother. Okay, so remember these points. Which of the following molecule helps in the migration of WBC from blood vessels with the adhesion to the endothelium? Yes, it is PCAM. PCAM, very good. PCAM one. So you can remember that the steps in the cellular events. It is the axial blood flow, margination, rolling, adhesion, and e-migration, then chemotaxis, and then the phagocytosis. For rolling, you need the silent lubis present in the For rolling, you need silent lubis present in the WBC and E-selectin present in the endothelium. For adhesion, you need integrins present in the leukocyte and ICAM1 present in the endothelial surface. And PCAM1 is needed for the E-migration. And guys, you will remember the chemotactic factors, LIC, leukotriene B4, yes, interleukin 8, yes, and C5a. Remember, C3b is for opsonin, C3b is for opsonin, and membrane attack complex, it is C5 to C9, membrane attack complex. And guys, you will also remember the mechanism of phagocytosis. Phagocytosis, oxygen dependent. Main, there will be oxidative burst will be there. NADPH oxidase will be converting that oxygen into superoxide. Then superoxide will be converted into hydrogen peroxide. Hydrogen peroxide will be converted into hydroxyl ion. Hydroxyl ion is the most potent free radical, and this will be combining with the MPO, myeloperoxidase, and the halide ions, and they will be giving that hypochlorite, most potent bactericidal agent. So remember that. What will happen in chronic granulomatous disease? This NADPH oxidase will not be there. So there will not be respiratory burst. So the free radicals will not be formed. NBT test. Remember chronic granulomatous disease, NBT test and dihydrorhodamine test. NBT la blue color irunduchna, that is normal. Blue color illana, the patient is having chronic granulomatous disease. Which is the disease in which the patient will be albinism, silvery has repeated infections, giant granules in the neutrophils, thrombocytopenia, all these things. Yes, peripheral neuropathy, that is Chediak-Higashi syndrome. Chediak-Higashi syndrome. Woolly hair woolly hair is in the Naxos syndrome. Okay, so remember all these things. Yes, very good. Yes. The final question here is for today's discussion. Total WBC count in the patient is this thing. So WBC count is elevated. Patient is increased in myeloid series, right shift, and eosinophilia and basophilia is there. So this is a case of CML. Fish is the diagnostic choice. So remember the three phases of the CML: chronic phase, accelerated phase, and blast crisis. Chronic phase, it is the blast count is going to be less than 10%, and accelerated phase, it is between the 10 to 19%, and in the blast crisis, it is going to be more than 20%. So there you will blast crisis, you will call that CML transforming into AML. And in the basophil count, in chronic phase, it is going to be less than 20, and in the accelerated phase, it is going to be more than 20 basophils. Yes. So these are the questions I had for you now. I think in this we covered almost the major topics in the neoplasia. So if you have any doubt, you can ask me. Yes. Or else, thank you very much for the very interactive session. You people interacted well. Yes. So with this spirit, with this fast revision, so one thing, just one point, in the Madidam faster you have to revise. So quick and question answer high yield topic. So on the Madidam faster revise pannano. This time short time you have to cover the maximum thing. நீங்க வந்து daily custom model questions போடுவீங்க எல்லாமே பண்ணுவீங்க, but you have to do a fast revision. So either tuck, 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 upon that subconscious mind length, you will be getting that things. Revision as well as solving MCQs, both are equally important at this point of time. So definitely you have to do a fast revision, and I am 100% sure all of you are going to get a good rank and get a good seat in your good institution. Okay. So wish you all the best. God bless you, my dear students. Thank you all.